I want to do is instead, so I know that last study session, we went through those last 2 pages. And I think what's happening is we're getting so caught up, like at the beginning of our study sessions in like the first 3 pages of the notes, and we're doing really well on those. What was that?
Yeah, I agree.
So what I've done is, if you look at the slide deck, I was using Google Docs or Google Slides, but I'm going to go back to PowerPoint because the functionality of Google Slides is hard for me to follow.
Okay.
And so so if you look at my slides, you'll notice it says page 1. And so what I've done is the slides behind that are all from page 1 of the notes, and I've done every page. And so what I've tried to do, and I haven't been totally successful yet, but what I'm going to do is I'm going to really rush through, and I'm going to do like one concept in each set of notes each day, each page, to force us to get through the whole thing every time we go through this.
Yeah,
and that way we won't get caught up and stuff. And so my goal is like at the first 4 sessions to basically get through these notes pretty well, and then maybe like on Saturday or Monday to start look at Unit 8. Does that make sense?
Yeah.
Start to peruse that. So we got maybe like 2 days to look over Unit 8 before we go to class, not get hijacked off of Unit 7, but then when we hit class on Tuesday, it's review. It's not new. We're the ones who know what's going on because we reviewed it and we're familiar with it, and we have questions. And
well, I think Addie does a good job with that too.
Yeah. Well, and so she's gonna be there on Saturday in person. But here's the deal. The reason that she's able to do that is because her class is ahead. After tomorrow, they will not be ahead of us. She'll be behind us. We'll get the lecture before she will.
That's true.
So in that context, she won't be ahead of us anymore. And so she won't be as much of a good resource for that because we'll be ahead of her. So she'll be coming in on a Tuesday or Wednesday, and she'll be hearing about stuff she's going to be going to class to hear. So just where those are just some subtle changes that I'd like to make to what we're doing, because I think you and I responded really, really well to the quiz this week because we were really ready. I mean, let's be honest.
Yeah.
So,
I feel like I wasn't as ready as I should have been, honestly. But
but
I did fine.
Yeah. So we just need to drive the train in a way that lets you be part of, feel good about it. But I think overall, I don't think we need to be doing more. Now we need to refine what we're doing, and then we need to just push it to the end.
I agree.
Okay. So let me ask you a question. I'm going to make these slides large to the present mode. Are those large in the present mode on your screen now? When you click on my face, click on my screen. They're nice and big, right?
Yep.
Okay, so let's just go through this. So page 1, and again, this is going to be less of the quiz style. What was that?
Okay.
So what I got so far, I haven't. Again, Addison, I've been busy too, and whatever. So they're not in the quiz style yet. They're just more going over a key concept on each page, and I only got to the first 4 or 5 pages. So let's just get through this. And this is more of a perusal without looking at our notes. Let's go through this. So the key concept on page 1 was the question: what signs and symptoms would a patient have if the kidneys were not able to do these things? Okay. So do you remember the 6 things that the kidneys do?
So they filter the blood.
Yep.
They they produce that what's it called?
Yeah, erythropoietin. What does erythropoietin do?
It signals to the the bone marrow to create
red blood cells.
Red blood cells.
So if that system stops, what would happen? So if we have a lack of red blood cells in our system, what's going to happen?
There would be that's like the oxygen carrying.
Yeah, that's hypoxia or anemia, right? Those are the terms that. So what I'm trying to do is, as you look through these 6 reasons or the 6 things that the kidneys do, if the blood stops getting filtered, what's going to happen to the body if the blood stops getting filtered?
Well, your body's just gonna. I don't know.
Well, it's bad. Your blood.
Kidneys are just.
Yeah, your blood's been poisoned. It's carrying the waste products of the body. So if the kidneys stop working, you get an increase of waste products in your body, and a waste product in the tissues, and
infection.
that's going to lead you to die.
Yeah.
That's like pissing in the gas tank of your car. Your car's not going to run very well if you keep doing that, right? Or changing the oil, right? We change the oil in our cars so that if you don't change the oil in your car, your engine stops working, and that's the same thing with the blood. Okay, so blood pressure. So one of the other things that happens is the blood pressure. Do you remember how blood pressure is regulated by the kidneys?
It's with the Well, okay, let me look at the notes.
Okay, so I'll help you a little bit. So what's going on with remember the kidneys have a certain pressure that they like to filter the blood with, right? There's a range of pressure, either too high or too low, and the kidneys can't do their job, right? The blood's moving too fast, then it moves too fast to the glomerulus, and it doesn't filter into the blood at all. If it's moving too slow, then the kidneys don't get the oxygen that they need, and they start to die, and that acid and poison builds up, right? Yeah. So kidneys, as soon as the blood pressure is too high, the kidney will start to signal, hey, you need to slow this down. And if the blood pressure gets too low, it also signals for that too and says, hey, this blood's moving too slow and it's getting dangerous for me. I can't do my job. And oh, by the way, I'm suffocating. Okay. Yeah. Without getting into the specific systems that do that per se, the kidneys have a certain blood flow pressure range they like. And if it gets outside that, the kidney starts to secrete signals to tell the rest of the body to do things to change that.
Yeah.
Okay. Acid-base balance. Okay. Do you know what acid-base balance, how the kidney controls acid-base?
With the reabsorption.
Well, yeah. Remember how we talked about there's free hydrogen? If you excrete that free hydrogen.
And the bicarbonate.
Yep. And bicarbonate. Yep. Exactly. So that's how the kidneys control the acid-base balance. Okay. You already talked about erythropoietin and then vitamin D. So it talks about making and releasing renin. Renin is part of the blood pressure system, so I don't want to talk about that one.
And that's with the RAS.
Yeah, that's the renin renin and angiotensin aldosterone system. Mm-hmm. And renin is kind of like the first step. Okay, and then the last one is activate vitamin D. Do you remember thinking about activating vitamin D? What was going on with that?
Because it's like you can't die. Wait, does it have to do with the intrinsic factor?
Well, intrinsic factors had to do with with platelets, right? So what happens with activating vitamin D? Vitamin D is what allows the GI tract to absorb calcium.
Oh, yeah.
So if vitamin D isn't activated or isn't allowed to activate because of the kidneys, then they have elevated calcium levels in our blood.
Okay. Yeah, that makes sense.
That says the GI tract would not be able to absorb as much calcium, so you would have the risk of hypocalcemia, or you'd have elevated calcium.
Which would be not enough.
Yeah, hypocalcemia is talking about in the tissues, and then we'd have hypercalcemia in the blood because the calcium's going to get out of the system somehow. Okay?
Yeah.
That's all I had from the first page. There's still some blood tests that it went over. I'm not going to go over those right now. Just to move on. Oh, wait, maybe I did go over some of these. Okay. So there are two types of tests that we do on kidney function. Do you remember what they were?
They do the one was called BUN, right?
Well, yeah, BUN is one of the tests. So the major systems that we do to test the kidney function are blood tests and urine tests. And BUN is one of the blood tests. We draw blood and we check for BUN, which is blood urea nitrogen levels in the blood, and that tells us about kidney function. Mm-hmm. Okay, so you're right. Do you know any other blood tests that we use to check kidney function?
You just blood? Well, I don't know.
Well, creatinine, right, which is a byproduct of muscle action, is a blood test. If we have elevated creatinine or that's in our blood and urine, then we know the kidneys aren't functioning as well.
Okay.
Okay, and then we have glomerular filtration rate, right? The amount of...
So question.
Yeah.
So if we just take a regular blood test and the creatinine comes out being like an increased level, that lets us know that it's something to do with your kidneys, right?
Yeah. So yeah, again, because the kidneys are going to filter that stuff, right?
And same with the bun as
Yeah.
well.
So remember with bun, remember the acronym 10 buns equals 20 butt cheeks?
Yes.
So you have a range, again, that's appropriate for the bun test. And so basically anything less than 20 is considered normal. Anything over 20 would mean there's something wrong with the blood urea nitrogen test, right?
Okay.
Okay, so I just want to make sure that we talk about those 3 tests tonight. So there are 2 major test systems that we use to test kidney function: blood tests and urine tests.
Urine.
Okay, on page 1, the 3 blood tests, the one that you knew was BUN, creatinine, and GFR are the blood tests. Okay, on page number 2, then what would be the 3? What would be the 2? What's the urine test that we use?
Can't we just do like a urinalysis?
So yeah, so we can do urinalysis, which is going to test the specific gravity of the urine, right? And specific gravity is in relation to regular water. So do you know the normal range of specific gravity?
It was like oh gosh, no.
Well, there were 2 mnemonics they talked about. The one was the clock mnemonic, 10, 10, 10, 10, 30. Or the other one that Megan said was 10 plus 10 plus 10 equals 30, or 1.010 to 1.030.
Yep.
Okay, and the notes, the flashcard I just showed has it on the mnemonic up there.
Yeah, I'm looking at it. Okay.
Okay, and then the other test that they use is creatinine clearance test. So the creatinine test is a blood test and a urine test. We're going to test it on both sides of the blood-urine barrier.
Okay.
Okay. Then on page 2, they talk about the renin-angiotensin-aldosterone system, RAS. I think we spent a lot of time. So let me do this. Do you remember anything about the RAS system from class that you can just off the top of your head?
Well, the kidneys release renin.
Yeah, so kidneys release renin.
Because of it was like a decrease, but I don't remember what it was a decrease in.
In response to low blood pressure, right? Kidneys release renin. And they went where? Where does the renin go?
Doesn't it go to like
renin enters the bloodstream?
No, does it? It goes straight to the bloodstream.
Renin enters the bloodstream and it interacts with a special molecule from the liver called angiotensinogen. So angiotensinogen from the liver and renin from the kidneys combine to become angiotensin 1.
Okay.
So the first 2 organs that respond to low blood pressure are renin from the kidneys and angiotensinogen from the liver. Those connect and they touch each other in the blood system, in the blood vessels, and they become angiotensin 1. From there, where do they go next? Where does the angiotensin 1 go next?
I have no idea.
So angiotensin 1 then goes to the lungs. In the lungs, it's going to meet up with ACE, which is angiotensin converting enzyme, and become angiotensin 2.
Okay.
Okay, so angiotensin 2 is converted from angiotensin 1 and angiotensin converting enzyme, or ACE enzymes, in the lungs. It leaves the lungs as angiotensin 2. Okay, where does angiotensin 2 go next? It goes back to one of the 2 starting organs.
The kidney?
It goes back to the kidneys by way of the adrenal cortex. Okay, so angiotensin 2 goes back to the kidney and interacts with the adrenal cortex to release aldosterone.
Okay.
And then aldosterone directs the kidneys to reabsorb sodium, right? It's telling the kidneys to reabsorb sodium. By reabsorbing sodium, what's happening? Where's the sodium going?
When that increase?
Yeah, it increases. The sodium passes back into the blood, and wherever sodium goes, what happens?
Then the water
follows, which increases the fluid content of the blood, which is going to drive blood pressure up.
Okay.
Remember also the angiotensin 2 has a special function as well to help increase blood pressure. It causes the pituitary gland to also secrete ADH, or antidiuretic hormone, from the pituitary gland. So there's two systems here that are working. One at angiotensin 2 and one with aldosterone coming out of the adrenal cortex of the kidneys, okay? And both of those systems work to drive the blood pressure up.
Okay.
Okay, we good?
Yep.
Okay, let's move on to page 3. I had the key terms up, so I just put the in-class notes, key terms, page 2. So azotemia means an increased bun and an increased creatine level in the blood with no systemic signs and symptoms. Uremia is an increase in blood and increase in creatine in the blood with systemic signs and symptoms. Okay, so those two are related. One doesn't have signs and symptoms, and one does. Okay.
Okay.
So then polyuria is an increase in urine output. It can be pathogenic from diabetes, or it can be I just drank too much. Whether that's water, alcohol, pop, Gatorade, whatever, you drink too much, you pee more. And that's
poly.
What was that? Poly means more or many.
Yeah, okay.
So more urine is what actually means. Then oliguria means urine output can be measured by dehydration. Drink more. It means decreased urine output. Oliguria, and that's an indication that you need to drink more, or it can be a sign of kidney failure. So oliguria can be just a normal response that you didn't drink enough. It doesn't have to be pathogenic. Okay. When oliguria translates into an anuria, then it becomes kidney failure. It's a definite sign of kidney failure.
Okay.
So between oliguria and anuria, which one's worse?
Definitely anuria.
Yeah, because anuria, you've reached a situation where you are definitely not creating any urine. Oliguria means that you've got a reduced urine output, and it can be an indicator that your kidneys aren't functioning as well, or it can be that you worked out in the yard too long and you didn't drink water today, right? And you just worked out too much. Okay. Yep. Like at your job, you're probably doing a lot of running around at your job, more than you were doing before, right?
Yep.
Maybe you get a little bit more fluids now.
Yep.
Okay. So now we're on page 3, which is, again, the first concept is talking about ADH. So what's ADH? You're right.
Antidiuretic.
Yeah, antidiuretic hormone, and it's also called, the street name for it is what?
Well, I'm looking now. It's called vasopressin.
Yep, vasopressin. Yep. So that means the same thing, right? So if you see vasopressin, it means ADH. If you see ADH, it means vasopressin. So it's secreted where? Where is it secreted from?
The posterior pituitary gland.
Yep. Secreted by the posterior pituitary, and it's released because of what?
To increased osmolality.
What that basically means is that there's not as much fluid or water component to the whole blood, and so it's getting more thick, right? So that the pituitary and the kidney can detect that, and so it's called that osmolality is increased, and so it just means that the blood is getting more thick.
Okay.
So in response to that, your body says, "Dude, stop pissing out the water." It releases it goes and tells the kidney to do what? Hold on to fluid.
Mm-hmm.
Okay, and then it just says regulates body H2O by signaling kidneys to retain sodium, which in turn does what?
It would.
When sodium is pulled back in the blood, what follows it?
The water.
Yeah.
Which would increase the blood pressure.
Yep. And then excretion of ADH is caused by low blood volume, a low sodium volume, or high osmolarity in the body fluids, i.e. dehydration, and then ADH will cause fluid retention to relieve dehydration.
Mm-hmm.
Those are the general notes that I had. Okay, page 4. The main thing on page 4 was pyelonephritis. So without looking at any of the notes, let's break down the word pyelonephritis. Can you break the roots down? What's the first root? Yeah, what was that?
I said nephron.
Yeah, so nephro or nephra, N-E-P-H-R, that's root, right? Meaning nephron. Pyelo means something, and itis means something. Do you know what itis means?
Like a disease?
Well, yeah, itis means to inflame or to swell,
Okay.
right? So, again, like anywhere, that's what it means. So nephritis means to swell the nephron, right? It gets swollen.
Yeah.
Okay, and then
Okay.
pyelo, I can't remember what pyelo means. Let me look it up. Let me Google it really quick. Because she told us in class. I didn't write it down. I'm kind of a dum-dum for that. I didn't write it down.
She said, let's see. I put pelvis of kidneys.
There we go. Thank you. The renal pelvis. That's what it stands for.
Okay.
I'll let you read the slide so you can get this one. I'll let you read it.
Okay, so bacterial infection that reaches the kidney by ascending the urinary tract or the bloodstream. This leads to renal scarring.
Okay. So in your own words, can you tell me what that means?
So when the bacteria reaches the kidney.
And how does it get there?
It could be from a UTI.
Yeah, UTIs, or it can actually enter because it comes in from the bloodstream. So there's two routes for it to get in there. And what does it ultimately cause to happen?
Bacteria.
Well, no, not the bacteria. The bacteria is the reason, right? But what does it do to the kidneys?
Well, it says renal scarring, but
yeah,
I don't know.
It causes damage to the structures in the kidney, specifically probably nephrons. So if you start scarring those tissues, do they want to work as well?
No.
No, right? We learned that that's metaplasia, and metaplasia means that they're protecting themselves, but the tissues that are replacing them don't function the same way. And so that's what's actually happening. Okay, cool. Okay, so the causes are UTI, and there was a special word for UTI in this section.
Cystis?
Yeah, cystitis, right?
Cystitis.
Okay, urinary tract obstruction with reflux infection, E. coli, Proteus, or Pseudomonas. Okay, so when it says urinary tract obstruction with reflux, the reflux part of that statement means that it's backflowing. So in the case of UTI, you're getting a UTI in your lower renal system or down by your urethra. It's infesting there, and that is moving back up through the urethra, up into the bladder, back up through the ureters, and then it actually enters the kidneys that way.
Okay.
And then each of these three bacterias, E. coli, Proteus, or Pseudomonas, those are the three main bacteria that we associate with this.
Okay.
Okay. Who gets it? Obviously, we know females develop this a little bit more readily than men. And then urinary backflow is the most common cause. It can come through the blood, but it's the most common cause.
Yep.
Okay.
Or catheters.
Or catheters. I mean, there's a couple of reasons, right? But we'll dig in. We're going to get more detailed as we move into the week with this. But again, you see how we're getting through pages now? We're not hitting every concept, but we're starting to move through the whole worksheet. Okay, so I have nothing for notes number 5. So from here on out, we'll just have to look. So what I'll let you do is I'm going to let you look at notes for page 5 really quick. And then, yeah, I'll let you look. What the hell? I'll let you look at number 5 real quick, and let's go through it together and just pick a concept. We'll just pick one concept. Let's go through that and then move on to 6.
Okay. Well, I think a main topic of page 5 is the glomerular disorders.
Okay, so where are the glomerular at? Where's that at? In the kidneys. Can you tell me where that's at?
In the... Isn't that in the neph? No. Isn't it a glomerulus?
I'm going to draw a picture.
Okay.
Give me 1 second.
I need to go over my anatomy.
Okay, so can you see my worksheet here?
Yep.
Okay, so I'm going to put an arrow pointing towards the glomerulus.
Okay.
In the structures of those nephrons, that's the glomerulus, that bulb right there.
Okay. Yep.
Okay. And why is that the most important structure? What's going on in there that makes it so important? I'm going to help you a little
I
bit.
don't know.
So about 70% of all blood filtration is happening in the glomerulus. That's the first stop for unfiltered blood. It enters through the afferent atrial, enters into there. It starts to get filtered in the glomerulus, in the Bowman's capsule, and then it goes out the efferent neuron, the efferent atrial, and goes out, and it mirrors the nephron loop, so that then again a little bit more absorption and reabsorption can happen outside the glomerulus. But about 70% of the filtrates are going to come out right there.
Okay.
So if you start having damage to glomerulus in your structure, that's really where kidney destruction's at. It's really there.
Yeah.
Yeah, it's that thing that's getting killed. It's really getting you in trouble. If your nephrons get damaged, yeah, that's bad. And it's going to allow some filtrates to reabsorb back into your blood that shouldn't, and vice versa, fluid to leave that shouldn't. But at the end of the day, the major damage is going to be in your glomerulus. That's where we're really concerned. And that's the structure that has the most sensitivity to the blood pressure changing.
Okay.
Okay. So in here, it talks about acute glomerulonephritis. So if it's glomerular nephritis, what's going on?
Well, itis is the inflammation.
Yeah, and it's due to an infection. It's due to infection. So in this, it talks about there's two kinds. There's primary and secondary. The primary is caused by group A strep, and then secondary are caused by diseases and conditions that are on the next page. But the main one is strep. Strep's causing it. So the strep is entering the glomerulus structure, the Bowman's capsule. It's being attacked by antibodies. The immunoglobulins are bonding with the strep, and it's creating large infectious molecules and structures that are moving through the glomerulus. And what do you think they're doing in there?
Well,
are the nephrons designed to support large molecules?
No.
Yeah, they only really want to see one thing. What is it?
The glomerulus? Is that
yeah,
what
they
you're
only
saying?
want to see one kind of structure.
Blood.
Yeah, the red blood cells, right? That's all they really want to see. So if you start sending sharp proteins and like immunoglobulins through there and strep bonded stuff and blood clots, what do you think the glomerulus does when that happens?
It's going to get backed up, probably.
Yeah,
because
they're going to get backed up, or they're just going to get beat to hell. They're going to get damaged. That stuff's going to bounce around through there, and it's going to destroy that. It's going to destroy that pump and that piping in there. It's going to bust it all up. And so then those guys can't filter anything because the cells that make up those walls are completely blown off.
Yeah.
That's what's going on. Okay. So let's do this. So when the kidneys get damaged this way, what's the major sign that we can see in a patient when the kidneys are getting damaged by glomerulonephritis and we got those molecules bouncing through the glomerulus and tearing up the walls? What's going on? What is a patient going to look like?
Well, you'd be peeing out proteins.
That's one of the things that we're going to see, right? But what's going to happen? They're going to be edema. Patients going to remember those cat eye people, the raccoon eye, swollen eyes.
Yes.
It's that kind of edema that we're going to see in people that got this kind of damage in their kidneys.
Okay.
Okay. Yeah. Well, let's move on. Let's move on to page number. That was page 5. Let's go to page number 6.
Okay.
Okay. So there was 2 things here: nephritic syndrome and nephrotic syndrome. Can you tell me the difference between those two?
I is the loss of the blood.
Yep.
In the urine.
Okay.
And
that's called hematuria. The term for that is hematuria.
What did you say?
When blood is in the urine, we call it hematuria.
Oh yeah.
Okay. You got it. Okay.
And the nephrotic is a loss of a lot of protein, which is the proteinuria.
Yeah, proteinuria, right?
Yeah.
Okay. So let me ask you a question. Can you have nephritic syndrome that has protein as well as blood in the urine?
Yeah.
Okay. If you have nephrotic syndrome, are you going to have any blood in the urine?
Probably, yeah.
No, and I got this wrong in class. Why is that?
Well, what if you had like a girl? What if she had blood?
Even a girl. So if you have nephritic syndrome, because what's happened is the damage to the glomerulus is the holes in the glomerulus are so large, it's letting blood cells and protein cells through. In nephrotic syndrome, the holes are not big enough to let red blood cells through. It's just big enough to let those smaller plasma proteins through. And that's why you don't see blood in the urine from nephrotic syndrome. If you have a girl that has nephrotic syndrome in addition to blood in her urine, it's because maybe she's menstruating and it's getting mixed at the urethral opening, vaginal opening. But it's not because she's presenting with both at the same time.
Okay.
So you're right. That would be a contraindication. It would make it a little bit harder to detect that in a girl. But the way to detect that would be to just do a catheter, right? To isolate her urine from her menstrual flow, and then check her urine, and there would be no blood in it, and then you'd know it was nephrotic.
Okay.
Okay, we good?
Yep.
Okay, let's go on to page 7. Okay, so there's a big thing on this one.
Acute tubular.
Yep. And what did Kapana say about this one?
This is like the worst case scenario.
Yep. This is the widowmaker, right? You get this going on, and you're basically losing kidney function. You need a transplant. Your kidneys are not functioning anymore. So let's do this. Let's just read the first 2 paragraphs below this one. And because again, I'm still learning this one with you. I'm gonna need some more time to look over this to get a little bit more of my handle on it. But I think we both would benefit by reading it out.
Yeah. Okay.
So acute tubular necrosis, ATN, damage to the tubular cells of the kidney, which can lead to acute kidney failure. Acute tubular necrosis, or ATN, is usually caused by a lack of oxygen to the kidney tissues or ischemia of the kidneys. It may also occur if the kidney cells are damaged by a poison or a harmful substance. Do you want to read the next paragraph?
Yeah. ATN is one of the most common causes of acute kidney injury failure in hospitalized patients. ATN is reversible in most people. I don't know what that word says because I hole punched it out.
The failure.
No, it's above that.
The goal.
The goal of treatment is to prevent life-threatening complications of acute kidney failure. Treatment focuses on preventing the excess buildup of fluids and waste while allowing the kidney to heal. Patients should be watched closely for deterioration of kidney functions.
So can I ask you a question about this?
Yeah.
So there was a statement there that said treatment focuses on preventing excess buildup of fluids and waste. So what is that basically saying? What kind of treatment would we be giving somebody to treat this?
What kind of treatment would we be giving?
Yeah, what kind of treatment would you give a patient to treat that?
It'd be a hypotonic.
Well, no, not the solutions. That's dialysis. That statement is dialysis. You would be filtering their blood for them to keep from getting fluid buildup and waste, right? By doing dialysis for them, you're controlling the amount of waste and fluids that are being removed as a nurse or as a caregiver. And then while you're doing that, it's allowing those kidney cells, those kidney structures to relax and to heal.
Mm-hmm.
So I just wanted to make sure that when you read stuff like that, you can kind of translate and say, they're really saying that you're providing some kind of dialysis to them.
Okay.
They're intervening rather significantly right there in that statement.
Yeah.
Okay. That was it. That's page 7. Let's move on to page 8.
Okay.
So renal failure, acute and chronic. Okay, so when we say acute, what does that mean?
What'd you say when we say acute?
Acute renal failure as opposed to chronic renal failure.
Well, acute is anything that is gonna get better, basically.
Yeah, and here in the notes say it's potentially reversible. So it's brought on. Yeah. It's a quick onset, and it means that we can probably also relieve it and fix it. Chronic means what?
It's going to be over at least 3 months.
Yeah, and they're gonna. Yep, you got it. Keep going. Sorry, keep going with your thought.
No, that was it.
Yeah, they're gonna need a kidney transplant, or they're gonna be on dialysis at that point.
Yeah.
So that's again. So acute tubular necrosis is going to lead to kidney failure, and both of them have the same kind of outcome. They're going to progress to kidney failure, which is going to lead to either transplant or dialysis, or both. Obviously, go on dialysis until you get a kidney transplant.
Yeah.
Okay, that was page 8. Okay, and then page 9 takes the majority of page 9 is talking about
chronic renal failure.
Yep, chronic renal. So we don't really get that. I mean, we get like half a page on acute renal kidney injury, and we got like a freaking whole page on a chronic renal. Oh, and then the next page, page 10, has that flow chart of kidney diseases.
Okay.
So between acute and chronic, which one's we gonna spend the most time talking about?
Chronic.
Yeah. Okay, let's go through this. Let's go through this cheat sheet between chronic kidney injury and chronic renal failure. So there's comparison of acute and chronic renal failure. So I'll read through the acute kidney stuff if you want to do the chronic stuff.
Okay.
So acute kidney injury, decreased blood flow, i.e. acute tubular necrosis to the kidneys for 20 to 30 minutes may occur from blood loss, surgery, cardiac arrest, or shock, obstruction or blockage along with urinary tract triggers the inflammatory response of the body, or E. coli infection to the kidney. Glomerulonephritis, a glomeruli becomes inflamed due to development of large antigen antibody complexes and the molecules which impairs the kidney's ability to filter urine. And then nephrotoxic medications cause damage to the kidneys that lead to ARF, or acute renal failure.
Okay.
And that was the whatever, that streptomycin or whatever was the major medication they were talking about.
Yeah.
So we'll have to look that one up. I don't know if it's the right one. Okay, chronic.
Diabetes is high blood sugar damages blood vessels throughout the body, especially in the kidneys, which prevents filtration of waste products from the body. Hypertension, high blood pressure damages the kidney filters, which then increases blood pressure even more. Nephrotic syndrome, a condition that has several different causes. Nephrotic syndrome is characterized by protein in the urine, low protein in the blood, high cholesterol levels, and tissue swelling. Chronic obstructions can cause urine backflow, hydronephrosis, and increased pressure in the kidneys that leads to CRF.
Okay.
Chronic
That's 9. So let's look at page 10 really quick. And let's go through this chronic kidney disease flow chart. And let's kind of talk about these. So sodium water balance. So remember what's the key thing with sodium water balance that we got to remember?
We're wanting to increase the blood.
Well, not necessarily increase. Basically, the key thing with that is where sodium goes, the water's going to go. So if sodium is flowing back into the blood vessels, what's that going to do to the blood pressure?
It's going to increase it.
Yeah, it's going to increase blood pressure, right? If we're pulling sodium out of the blood vessels and back and urinating them out, or pulling them out and they're entering the urine and leaving the body, what's going to happen to blood pressure?
Decrease.
It's going to decrease it because what's going with it?
The sodium with the
sodium's going to go with that. Yeah, with the water's going to flow with that sodium out of the body. That's going to decrease the blood volume, which is going to drive the blood pressure up, or it's going to increase viscosity, which will drive blood pressure up. It's going to drive the blood pressure down because blood volume is lower.
Mm-hmm.
Okay, and so it talks about here where hypertension and so it leads to heart failure and edema. So that system can lead to those two things. What about potassium?
Okay.
What's the thing we're looking for there?
With what? Potassium?
Potassium balance. So the only thing under potassium balance, it talks about hyperkalemia. or elevated potassium levels. If we have hyperkalemia, what system does the potassium work on from our electrolyte lecture?
Oh, isn't it the heart? No, it's the muscle, like the smooth.
Yeah, well, it just means that it's going to affect the heart, and hyperkalemia is going to cause it to drive the heart rate up. Elevated potassium could cause the heart rate to go up. So now we've also affected the blood, the sodium water thing. We can kind of look at some of those signs and symptoms too, because hypertension leads to heart failure. Well, then elevated potassium levels and hyperkalemia could potentially do that too.
Yeah.
Or it could just aggravate it. If you already have hypertension and you're holding potassium, it's going to drive the heart rate up.
Mm-hmm.
And we can double check that tomorrow. I got a little thing I want to build for those electrolytes. Addie gave it to me, and I want to build a slide in our slide deck to review those electrolytes in a little bit different way. And we'll go over that again tomorrow because I need a good review of that too. Those are starting to become sketchy in my mind.
Okay.
So elimination of nitrous gas waste. Nitrogenous waste is uremia, and then that was coagulopathy, which means bleeding. That's one of the symptoms. And then pericarditis means inflammation of the pericardial sac of the heart. And then impaired immune function, skin disorder, gastrointestinal manifestations, neurologic manifestations, and sexual dysfunction. So make sure you're taking care of your nitrogenic waste because there's a lot of things going on with that. Okay, erythropoietin production.
Anemia.
Well, anemia. So why would you get anemia with that? Does that mean that you're producing too much or too little of erythropoietin?
Too little.
Yeah, so kidney failure.
Anemia.
Yep, is going to cause anemia or lack of erythropoietin, which is going to cause anemia. Acid-base balance. What do we talk about acid-base balance? If the kidneys stop functioning, what's going to happen to acid-base balance?
Acidosis.
And why are we having acidosis?
Because we don't, our balance is becoming acidic, basically.
Yeah, we're not pissing off that free hydrogen. So instead of releasing it as urine, in the urine, it's being held on in the body and re-entering the blood system. And so our blood's getting more acidic because we're not able to pee it off. And then skeletal buffering, dystropias, activation of vitamin D. What was the activation of vitamin D?
That was go back to the vitamin D, which was,
it's GI based, right? It's GI.
Yeah.
So vitamin D allows us to do what?
Don't tell me. I want to look, but I shouldn't.
Look at the flow chart. Look right under vitamin D, and it goes off to the right. What's it say there?
Hypocalcemia. Oh, the calcium.
Yeah, the GI tract can't do what?
Produce calcium.
It's not producing calcium. It just can't take it up. It can't take it up. Okay, we're not producing calcium. We're just whatever's there. It can't be taken in.
Yeah.
And then phosphate elimination causes hypocalcemia, and that causes hyperparathyroidism. So your thyroid starts going crazy. Okay, I think we beat the crap out of that. Okay, page 11. So
are we studying in the morning?
Yeah, let's do it. I'm gonna work on this tonight. I got some time at work. I'm gonna work on some of this.
Okay.
And then if you have a few minutes before you go to bed, build a couple of slides and throw them on here.
Okay.
Because I think this is working though. Because what have we done tonight? It forces us to work through every page of the stinking thing.
Yeah.
Okay, so highlights, lesson highlights, and question practice. So anemia concepts to understand. A nurse uses their understanding of the different presentations of edema to help determine what is wrong with the patient. Fill in the blanks below with the correct type of edema for the listed condition. So chronic heart failure. So what's edema?
Wouldn't that be
Retention of fluid in the tissues.
Okay.
So if we have chronic heart failure, where are we going to see edema at? Where are we going to see fluid retention?
Oh, okay. So that's in the tissues.
Yeah, so if we have chronic heart failure and blood stops moving, where is the first tissue that's going to start filling up with fluid?
The
lungs. Right and left heart failure. The first tissue to get edema. Pulmonary edema is going to be the first thing that we see.
Yep.
Okay. Deep vein thrombosis.
That's the clot.
That's a clot where?
In the vein.
A deep thrombosis, right? So what kind of veins are we going to see that? Peripheral veins or veins in the core of the body?
Peripheral.
Peripheral, right? So let's just say the right leg has a deep vein thrombosis. What kind of edema are you going to see down there?
It's going to be, I forgot what it's called, but it's when like the swelling, like it won't bring anything back up. It's going to get
nothing can get out of there, right?
Yeah.
So you get blood backed up, the pressure backs up, and so the pressure starts forcing fluid out of the blood into the tissues, and you get that kind of edema there. What about local inflammation? What's going on there?
With edema, that would be, well, that's just local inflammation.
Yeah, bee sting. Just think bee sting, right?
Yeah.
So anaphylaxis, bee sting. What kind of inflammation do they get?
That would be the first phase, which is. Are you talking about the acid thing?
Well, they get local inflammation around the site of the sting, and then everything else that happens with that is because of histamine. The histamine starts filtering through the system. So So again, so the swelling in your throat, right, that causes an occlusion of their airway. That is inflammation because of edema. That's inflammation because it's reacting with the smooth muscles of the throat, and it's causing them to constrict, right? But the edema they're talking about with local inflammation is just localized around the point of injury.
Okay.
That's where the fluid buildup is. Okay, what about kidney failure? What kind of edema are we going to see with kidney failure? What kind of kidney failure is raccoon eyes?
The chronic one?
Yeah, chronic nephritis, right? Is the raccoon eyes, or acute tubular nephritis, or acute tubular injury, or whatever it was?
Yeah.
So, but we learned with kidneys, you're going to get body-wide edema. It's going to be all over the body. They're going to get it in their arms. They're going to get it in their legs. They're going to get it in their face. Where CHF, chronic heart failure, they don't get it in their face. They get it in their lungs. Where with the kidney failure, you're going to see it all over the place.
Yeah.
Okay. And we'll get this a little bit more. I think there's a little bit more that they're asking for this. But I think maybe Saturday study group, or maybe tomorrow, if we can look at this overnight or take a few minutes. If you don't get to it, it's fine. But I think that's what they're asking us to do with these is what kind of edema are you going to see with heart failure? What kind of edema do you see with local inflammation?
Yeah.
And you think about it, okay? Okay, so lab values, remember, okay? So bun, what was the lab value for bun?
It was less than 20.
Less than 20, specific gravity?
10, 10, 10, 30.
Yep, 10, 10, 10, 30. Sodium?
135 to 145.
Potassium?
3.5 to 5.0.
Yep. Calcium?
8.5 to 10.5.
Yep, and then magnesium?
1.5 to 3.0.
Okay. So it's 10 to... Okay. So I'll leave 12 and 13 for another time because they're just questions and stuff. And 14.
We can do those Saturday.
We can do them Saturday, or we can even do them tomorrow because like number 8, it says matching RAS to appropriate organ to origin. You and I can go through that tomorrow morning. We should already be able to do some of this.
Okay.
We'll look at these tomorrow and see how much of it we can get through. Because remember, Addie hasn't had these yet.
Okay.
She is going to not have class tomorrow, so she'll be behind us. So you and I will be helping her now, which will be good for us.
Oh yeah, because it's
They don't.
tomorrow.
Tomorrow's fall break for them.
Oh yeah, okay.
No class tomorrow. Okay, so you got any other questions? Anything for me?
Um, other than the fact that I got my schedule for the next couple weeks.
That's
So,
fine. Text it to me or whatever, and then we can figure it out. We know we're going to
okay.
be either meeting at 8:30 or 9:30 or 9.
Yeah.
That's pretty much it. It's just a matter of which days we're doing what, and just as long as we keep doing this and staying on it, I think, like I said, we're already ahead because we're meeting earlier now. We're meeting on Wednesday, which we didn't do last week, and we're already ahead. So I think this is working.
Oh, I do too.
And you know, if you come home from work tired tonight, you wouldn't have studied.
Well, I am tired.
You would have.
I still
Yeah.
studied.
What was that?
I said I am tired, but I still studied.
Okay. Would you study at work, or would you come home and studied?
Come home.
You would have come home and studied. You're such a good student.
Well, only for like 10 minutes.
Oh,
And then I fall asleep.
So you wouldn't have gotten an hour. You would have just gotten 10 minutes.
Exactly.
Okay. You would have gotten into this just enough to like say you studied, but not remember anything.
Yep.
Just not to make yourself feel good, and then you're like, I'm out.
Yep.
Okay.
Read over it once.
Have a good night. I'll let you go. And but no, that's good. We got through it. So we'll just keep working and picking at it. If you want to make some slides, go ahead. I mean, obviously, from page 5 on, I haven't done any slides. So if you want to make 1 or 2 slides before you go to bed, you got like 7 minutes back from our study group. Take a few minutes, make some slides.
Okay. I think what I'm going to try and do is make because tomorrow I have some free time afterwards. I kind of want to draw out a system for the RAS.
Okay, that's fine. We can do that.
Of actual things that we can cut out and put together, like a diagram.
Like we did, like they have a little heart and all that stuff.
So then on Saturday we can match the things with.
That's fine. That's absolutely nothing wrong with that, and I value that because again, you're bringing to the table a totally different learning style, and I'm totally okay with that.
Okay, perfect.
Cool.
Okay, well, I will talk to you in the morning then.
Okay, I will. Same bad time, same bad station.
Okay.
Okay, have a good night, my dear.
You too.
Okay, bye.